Dr. Siesling.
Thank you. I just slightly shortened my title to get to the point of my presentation. I have nothing to declare. The background of this study is that in randomized clinical trials, we found that breast conserving therapy, which is breast conserving surgery combined with radiotherapy or radiation therapy, and mastectomy had the same survival. And therefore, in the guidelines in the Netherlands, it is stated that patients with early stage breast cancer, which means breast cancer smaller than 5 centimeters, with or without a limited lymph node invasion, have indication for either breast conserving therapy or mastectomy. Recent observational studies, they implied that there was better survival in patients with breast conserving therapy. And these observational studies were limited to 5 years of follow-up, and we all know that survival is quite long in breast cancer patients, as 5 years is quite short. So therefore, our research question was, can we find difference in overall survival in distant metastasis-free survival in patients who are treated for breast conserving, with breast conserving therapy or with mastectomy in early stage breast cancer? And we conducted this study on observational data from the Netherlands Cancer Registry, which is a cancer registry covering all of the Netherlands. We have 17 million inhabitants, and our data managers are in all 90 hospitals, gathering the data on tumor, patient, and treatment. We selected all women with early stage breast cancer diagnosed between 2000 and 2004. For the first cohort, we had the research question on the 10-year overall survival, and we had more than 37,000 patients included. And for the second outcome, which was distant metastasis-free survival, we had data from the cohort of 2003. For that, the data managers went back to the hospital and looked in their patient file whether there was diagnosis of distant metastasis during follow-up. And these were more than 7,500 patients. We performed Cox regression analysis, and we stratified for tumor stage in T and N stage. The results first of the overall survival was that in more than 58% of the patients received breast conserving therapy. And these patients were more younger and had more favorable tumor characteristics than the patients in the group who had mastectomy. And when we look at overall survival, the left graph is the survival of the different subgroups of tumor stage. And we see that if the tumor is larger than 2 centimeters, which is the 2 dotted lines below, the survival is worse. And on the left, you see the figure of the survival of the whole group. And you see that the breast conserving therapy group has better survival than the patients who are treated with mastectomy. And these results were comparable in the different staging subgroups. So T and N0, so tumors who are smaller than 2 centimeters without lymph node invasions, and the other subgroups had the same results. Breast conserving therapy is better than having a mastectomy. When we conducted the Cox regression analysis, we could adjust for confounding factors like the difference in age and the difference in hormonal therapy and other differences between the two groups. And we saw that there was a hazard ratio of 0.81, which means that the breast conserving therapy had better survival. And in the subgroups, we saw actually the same results. Looking at the distant metastasis-free survival in the subcohort of 2003, we saw that 61% had breast conserving therapy, in which 11% developed a distant metastasis in the meantime of 10 years of follow-up, and 38% had mastectomy, and they developed in about 15% distant metastasis. And the distribution of the characteristics were almost the same as in the total cohort, so we can distribute or extrapolate the findings to the total cohort. And what we saw is actually the same, that in the larger tumors we saw worse survival, and we saw better survival in patients who were treated with breast conserving therapy, which is the left figure in the dotted upper line. If we looked into the subgroups, we found this result mainly in the T1N0 subgroup, so patients who did not have any lymph node invasion and or lymph node involvement and had smaller tumors smaller than 2 centimeters. And we could not find this in the other larger tumor groups. So corrected for confounding, we found that there was a better survival in patients who had breast conserving therapy, which was mainly due to the fact that the whole group was dominated by the very small tumor groups. The limitation of this observational study, of course, observational study can be limited by confounding by indication. We corrected this for as much information we had on age or other adjuvant therapy. Still, there could be some residual confounding. We did not have any information on, for instance, comorbidity. And we did not have information on the HER2 status because that was not determined at that time. So no patient did have retrieved trastuzumab, for instance. To come to my conclusion, the overall survival for breast conserving therapy compared to mastectomy is better in every T and N stage, so in all tumor sizes. And the distant metastasis-free survival is mainly better in the patients who have tumors smaller than 2 centimeters without lymph node involvement. The main take-home message, breast conserving therapy should be a treatment of choice, especially in the smaller tumors, when it's medical feasible and according to the patient wish. Thank you.
Thank you, Dr. Siesling. A very interesting result. I think that, frankly, I probably would have expected the outcome to be the same in both arms in terms of survival. So can you speculate as to why you're seeing this difference?
We cannot see the difference in the subgroups for the distant metastasis-free survival. It's probably that the main group consists of the very small tumors, and we think that radiotherapy has an influence on this. The very small tumors are located and they do not have lymph node involvement, so the radiotherapy probably destroys all the tumor cells left. So the distant metastasis risk is less due to that. But we cannot really state that because of our lack of information of how many gray and how often they got radiotherapy.
So they may have been an imbalance in terms of radiotherapy delivery, because if you had a mastectomy, radiotherapy may not have been given then.
No. If in the Netherlands, mastectomy is given without radiotherapy, unless there are other indications to have radiotherapy. Okay. So that's the main difference between the two groups.
Okay. Thank you.
Excuse me, Charles Bankhead.